Hi, and welcome to IOL Radio. I'm Amy Peltier, Managing Editor of IO Learning, a digital publication geared toward interventional oncologists and the news source for the Symposium on Clinical Interventional Oncology. In this video, we will discuss the results of the TARGET study, which was recently presented at SIR in March. Our guest host today is Dr. Riad Salem, Chief of Vascular and Interventional Radiology at Northwestern Medicine. He will be speaking with Professor Marnix, one of the principal investigators of the TARGET study, and Professor of Nuclear Medicine and Chief of Nuclear Medicine at the University Medical Center Utrecht.
So welcome to this podcast today, talking about the TARGET results. My name is Riad Salem. I'm an interventional radiology at Northwestern, and it's a pleasure to have my friend and colleague, Dr. Marnix from Utrecht Medical Center, who's really going to be helping us understand the TARGET, the results, help us make sense of them and interpret them. I have done these podcasts already before, and they're really quite enjoyable because we get to hear experts explain the information, the data, help us digest it and incorporate it in our clinical practices. So it's really a pleasure to have Marnix here. Marnix, how are you doing today?
I'm fine, thanks, Riad. Good to see you.
Thank you. Good to see you too, Marnix. So congratulations, you presented TARGET as a late-breaking abstract at the SIR. This is something that you and I and Etienne collaborated on over several years. And I'm looking forward to talking to you about it for the next 30 minutes or so. And let's start just with some simple stuff, Marnix. Tell me about TARGET. What was the study, the design? Why is it important? What are your big picture thoughts about TARGET?
Well, I think we've seen over the years that there were many publications on dose-effect relationships. But of course, now there is the legacy study and we have the TheraSphere study. We'll be talking about that, I guess. But I think many of us question, like, can we do it ourselves? Is this something that can only be done in expert centers, in a research setting with highly selected patients? Or can we also do this in our clinical practice, in routine daily care? And I think that's the main purpose of TARGET, showing that this is doable, that everybody can do it, and that it also confirms in real-world data what the prospective studies show us.
So tell me a little bit, this is obviously a global study. Tell me a little bit about the scope, the global scope, the design of the study. Again, share with us this information.
Well, I think the main goal was to include as many HCC patients as we can, as we treat in daily practice, which means across the board, right? BCLC A, B, C, just the patients that we see every day, basically. That was our goal. And we recruited multiple centers across Europe, the United States, even in the Middle East, Turkey. So in total, we had 13 centers of different continents, and we recruited over 200 patients in total.
That's really very good. A lot of trials, as you know, try to do multi-center investigations and might have 1, 2, or 3 centers, et cetera. But here, with 13 sites in 8 countries, you know, that's quite compelling that you can perform this and demonstrate evidence that's reproducible with all these centers. Tell me about the role of simplicity in TARGET. How was that implemented in the trial, and your thoughts on that?
Well, I think it is super important if we do this that we have validated software such as Simplicity, a registered software package that was specifically designed for this purpose. I think this is very important from a perspective of standardization. So we all use the same method, basically. The TARGET study had 3 pillars. First, it had a preclinical assessment, basically, of all protocols used across these 13 centers in 8 different countries. So we really compared all the protocols that were used for imaging to see whether they were comparable. Secondly, we looked at intra and inter-observer variability using cases. So we had a round-robin analysis of multiple cases for all these centers to look at the observer variability. And both the protocols and the observer variability seem to be quite well, actually. And I think one of the main reasons is we use the same software, the same validated and standardized software to run these calculations. And then third, and I think this is from a clinical perspective, at least the most interesting part, is then we started running the analysis on all these 200 patients.
Mm-hmm. And tell me, you're able to become quite facile with simplicity relatively quickly. Is this something you're incorporating routinely now? Do you think this is something that can be generalizable to the general interventionalist, nuclear medicine physician, radiation oncologist?
Yeah, of course, if you implement new software, there's always a little bit of a learning curve, right? I mean, that's something we just have to acknowledge. But in fact, the software itself is quite intuitive. It was also designed with the help of multiple clinicians. So it's really meant for clinicians to use. You do not need to be a physicist to use this specific software. So it's definitely something you can implement in the clinics quite easily. There's also a different level of use. I mean, today we're also using what we call one compartment modeling. We choose an average absorbed dose in the perfused volume. And already to that extent, we also have to calculate at least the perfused volume, right? And that is already something that you can start doing in Simplicity today. And then I think at the same time, learn about the advantage of using a little bit more sophisticated dosimetry, such as we used in TheraSphere and also in Target.
Right. So let's start talking a little bit about the results. And just to clarify exactly, the primary endpoint had to do with grade 3 hyperbilirubinemias and normal tissue exposure. Can you expand a little bit on the rationale of that being the primary endpoint?
Well, we thought about this obviously, and we wanted to have an endpoint. I think the primary aim is that we treat our patients safely. And then secondly, of course, we want to be as effective as possible. So what we tried to define was what we called unacceptable toxicity. What do we believe is unacceptable toxicity? And then trying to define as an objective endpoint as possible. And that's where we came at grade 3 bilirubin increase or higher as kind of an objective measurement of unacceptable toxicity. And we wanted to relate that to the absorbed dose in the normal liver tissue, because that's the hypothesis. As the higher the dose, the higher the chance of having an unacceptable toxicity.
Yeah, I really like that. I think you and I agree that radiation toxicity and radiation injury to the liver is sometimes very loosely described and discussed by people without a thorough understanding of what it really means. Of course, disease progression can be a confounding variable, as you know, and people conflate these things many times. And so I think trying to isolate, dose and the toxicity is a very elegant way to try to answer this question and to look at it. And so let's continue along those lines of discussion. So it appears that you did not achieve the endpoint, or you did not achieve, you were unable to observe many grade 3s. Describe to us what you found when you started looking at the results.
Well, I think you mentioned an interesting point here, Riad. I think in general, looking at radioembolization treatments, toxicity is oftentimes over-reported, because we have to acknowledge that these patients that we treat, especially BCLC advanced stage patients, have a dismal prognosis. These are sick patients, right? Oftentimes they have progressive disease. So sometimes it's difficult to differentiate. Is this really treatment-related toxicity, or is it disease-related toxicity? In the Target study, we looked at grade 3 bilirubin increase, and we were actually quite conservative, using the definition that patients with possible, probable, or definitely related bilirubin increase, they were all counted as unacceptable toxicity. So that's quite a conservative approach. Even having taken this conservative approach, there were only 10 out of 209 cases with grade 3 bilirubin increase or higher. That's less than 5%, taking this conservative approach. If you really peel that down to the core, then I think that the real cases that we say, well, these were probably or definitely related to treatment, we only arrive at 1 or 2%.
And this is a really challenging assessment to perform, Marnix, right? Because these are cirrhotics as well, right? So they already have an embedded degree of untreated grade 3 toxicities that they will experience with no treatment because of cirrhosis, right? That's part of the natural history. And so it's interesting that you chose this conservative approach. And despite that, you really weren't able to see sufficient endpoints to make a conclusive statement. So let's talk about the safety then of what you've observed with target, the safety of TheraSphere. Tell us a little bit more about the outcomes around TAD, response, and survival.
As a secondary endpoint, I think it is important that so just to come back to toxicity one more time, I think what it tells you, the low incidence of toxicity really tells us that we can start optimizing our treatment. So we can now look at the tumor absorbed dose in more detail and optimize that tumor absorbed dose to have a sufficient tumor absorbed dose for a response in each individual patient, because the low toxicity does give us a lot of room for dose intensification. Having said that, as a secondary endpoint, I think a very important secondary endpoint, we looked at the dose effect relationship between the tumor absorbed dose and effect in terms of response, in terms of AFP levels, and in terms of survival. And in all three endpoints, there was a clear and significant relation between the tumor absorbed dose and all these response measurements. So it's really confirmatory. In all these instances, we see this a clear relationship between the two. So the higher the tumor absorbed dose, the better the outcome. That's the message.
I mean, that's very interesting, right? I mean, as you know, in the oncology space, using response either as a surrogate of survival or demonstrating a long-term benefit from that is very controversial, particularly in cirrhotic disease. There are some studies that suggest response rate is a surrogate of overall survival. Some counter that, but clearly you must believe that in some relationship, if you give the best dose, you get the best response, and as a result, the best survival. Is that a fair reflection of what your thoughts are?
Absolutely. Absolutely. And that is something that we not only see in target, but for example, also very, very clearly in TheraSphere.
So let's talk a little bit about TheraSphere. I think that's very important. So one of the things that I think we have all learned to appreciate over the last several years is the importance of dose. And let's spend just a few minutes on TheraSphere. Highlight for us sort of the big picture conclusions that you draw out of the TheraSphere findings.
I think the TheraSphere is a very, very important study. Why? Because for the first time, personalized dosimetry was prospectively used. I mean, we all tend to use it to some extent in our daily practice, but it was never compared to the, if I may, the old method. So what we always do is we use an average absorbed dose in our perfused volume. In the TheraSphere study, that was compared to an individualized treatment, really aiming for an optimized tumor absorbed dose while keeping normal liver absorbed dose below safety thresholds. And if you compare the two, and I think it's quite spectacular actually, to see that the response rate doubled. It doubled from an already fair 36% to 72%. 72%. If you look at the population of patients with a median tumor size of over 10 centimeter large, many of these patients had PVT, so really sick patients. And then if you are able to reach a 72% response rate, I think that's quite spectacular in that patient population.
Yeah, I would agree with you, Marnix. I think the TheraSphere is one of the most important studies to date on Y90. It was prospectively performed, as you mentioned. The patient population is a very advanced patient population, 10, 11 centimeter tumors, 2/3 with PVT. And in my opinion, when I discuss and debate a patient population that I think is underrepresented in other clinical trials, nobody's really enrolling these very large tumors with PVT. Nobody's doing that. You look at the clinical trials, it's not there. So it's really incredible that he was able to, as you mentioned, double the response. And to me, very interestingly, the ability to downstage or bridge to resection, I think is a very important concept, because while liver transplantation is a great concept, it's not applicable to those large tumors, 2/3 with PVT. And so we have to figure out ways to increase resectability of these patients that'll never get a liver. And I think 35% resection rate in these large tumors is really a spectacular finding.
Yeah.
One other thing I wanted to ask you about in terms of the multi-compartment dosimetry. So can you tell me a little bit about target multi-compartment dosimetry and TheraSphere multi-compartment? Are these the same? Are they similar? How can you compare and contrast?
I think of course the main difference is that TheraSphere was prospective, and we looked these dose effect relationship in retrospect, but we did use the same software, the same methodology, and it's actually simpler than it looks like. I mean, what we do is simply differentiating between the absorbed dose in the tumor and the non-tumor. These are the main compartments that we look at. And then what we find in target is that amongst patients, there's quite a bit of variability in tumor absorbed dose. If we just use an average absorbed dose, that will result in a high variability among patients. And that's I think important to see, because in these patients at the lower end, there's room for improvement. And that's exactly what TheraSphere tells us. We can double the response rate if we do it correctly.
Yeah, I mean, my observation is seeing what Etienne is able to do with those large tumors, gives me even more excitement as to what I can do with these smaller tumors in terms of achieving that response. And so with that in mind, I would like to bring in a little bit now the discussion of legacy, right? We've talked about target and the importance of dose in target. We've talked about TheraSphere, where prospectively the dose calculation was performed with amazing response rates and downstaging rates or conversion to resection. And then legacy that was just published in fact, maybe just a week ago, on also a cohort of individuals that got high dose. But your thoughts on legacy real quickly.
Well, what I very much like about legacy is especially that you see that the higher we start dosing, then we become ablative, and that's, I think, what the main message of legacy. We can be ablative. We can be ablative with minimal side effects. I think it's important for the audience to understand that for legacy, we're talking radiation segmentectomies. So that's a very, it's a different patient population from TheraSphere and target, obviously. Yeah. If we only target a small volume, 1 or 2 segments, we should go high. We should go over 400 gray. And if you do so, and I think legacy really nicely shows you that, then you have 100% necrosis after resection.
Yeah, and that's one of the things that we tried to do with legacy, is to capitalize on the tissue that we were obtaining from the resection specimens and the transplant specimens, because imaging is great, of course, but if you can get tissue and really look at what you are doing histologically, then it allows you to learn about and infer some things from target, infer some things from TheraSphere. I'd love to see the path explants from TheraSphere at some point, if Etienne's going to publish that as well. And that's why, like you mentioned, in legacy, we expanded the RAD path analysis to show what ablative dosimetry was. Our new number is 400, 410 gray, something like that. And you're right, we can be ablative. And that is a term that's usually only reserved for radiofrequency ablation. and in some cases as BRT, right? And so
Yeah.
I just think that with the three studies with Target and TheraSphere and Legacy, the idea that more focus, better dosimetry software, better dosimetry, you can get better absorbed dose, better response rate, and of course, link that to overall survival improvement. So I just think that these are very exciting combinations. When you put these three studies together, the trifecta, these three studies together, it really moves the dosimetry field forward.
Yeah, I think the what I like about Target is, I mean, it's real world data across 13 centers, 8 countries, and there's confirmatory data both for Legacy as well as for TheraSphere. For example, in the Target study, it was also observed that if the tumor absorbed dose was higher than 400 gray, the chances of complete response, a complete radiological response, went up. And that really kind of confirms the Legacy data. So obviously, from a tumor absorbed dose perspective, you want to go as high as possible. At the same time, it also confirmed the TheraSphere study, because we really saw a tipping point where chances of response started increasing at around 200 gray. And that was exactly the absorbed dose that was previously found by Etienne Garin and also used in the TheraSphere study. So it really shows you in real world data that this can be done in daily practice. It confirms TheraSphere in daily practice. And at the same time, it also confirms Legacy in daily practice. So I think these three studies together, they close the loop.
That's a really good way to put it. Target as real world data, multi-center international. TheraSphere is a controlled investigation in a well-selected patient population with the MAA uptake in the portal vein as a biomarker of response, right? I mean, a really elegant way to perform the randomization. And then Legacy with blinded independent central review, right? So this is not institutional investigator bias that clearly exists when you're looking at your own scans, but an independent group with 100% local control and ablative concept, right? So I think all these things really bode very well for imaging and dosimetry and follow-up and rad path correlations. Before we conclude, Marnix, what are your thoughts? What's next, do you think, in terms of what we need to look at from a dosimetry standpoint? There's a lot of focus over the last 24 months, thanks to you and Etienne, of course, in highlighting this aspect. What's next, you think, in terms of looking at these at dosimetry?
I think what's next, we have not that long ago, we wrote recommendations on dosimetry for HCC. You can see that the developments go so rapidly that we almost need to rewrite our recommendations.
Already obsolete, right?
This really shows you the level of development. That's unbelievable. But I think we're at the point. I mean, simplicity is out there. The recommendations are out there. I think we're really at a point to start using this. And I think it's, in my opinion, this is really about a combination of selection and planning. So what we try to do is we run our scout dose with MAA. We run the numbers in simplicity. We look at that. We bring it back to the tumor board and say, hey, is this a good candidate? Sometimes we do have these patients with relatively hypovascular disease in which you're simply not able to reach a sufficient tumor absorbed dose, for example, 150 gray max. And then maybe for that kind of patient, you should seek for alternatives.
Yep.
So it's a matter of selection. And at the same time, if it is a good candidate for radioembolization, we should plan that treatment on an individual basis, targeting for at least 200 gray to the tumor.
Using Simplicity software.
That's it.
Yeah, I agree with you. So I really do think this is exciting now with all of these studies that have just been presented over the last year or so, clearly moving the field forward. Marnix, I wanted to thank you for the discussion. I think this was really informative. Certainly, I hope the audience will learn from your experience And I look forward to talking to you and collaborating with you in the future. Thanks, Marnix.
Likewise. Thank you, Riad.
Thank you again to Dr. Riad Salem and Professor Marnix Lamb for being our guests today here at IO Learning. We would also like to thank Boston Scientific, manufacturers of TheraSphere Y90 glass microspheres and sponsors of this video. For more information about TheraSphere and Simplicity dosimetry planning software, please visit www.therasphere.com.